Hasta decente.
O sea que sí. Ah, bien, lo conozco siempre. Ah, bien. A ver, eso sí.
When you begin work today, this man could be one of your assigned patients. His total care is your responsibility. Lab tests may be ordered. Medications must be administered. Vital signs are monitored. Another aspect of the patient's care will include continuous monitoring of his EKG. This program is designed to help you learn the basics of interpreting the EKG. Once you've mastered the eight-step method demonstrated throughout the program, you'll be able to recognize a normal sinus rhythm and detect abnormalities. A review of heart function and its conduction system will help you understand the significance of each part of the waveform.
Monitoring a patient's EKG used to be unique to the coronary care or intensive care unit. However, today, it has become almost as commonplace as taking a patient's blood pressure. 12-lead EKGs routinely are recorded for many patients, both in the hospital and in many different outpatient care settings. Telemetry allows EKG monitoring of patients throughout the hospital. Phone lines can be used to monitor a patient's EKG at home. And remote capabilities permit monitoring patients in outlying hospitals, clinics, and nursing homes. So the opportunity to evaluate an EKG is likely to be encountered in all areas of nursing. And like any technical skill, practice, combined with an understanding of physiologic principles, is essential to your competent performance. Let's get started by reviewing the anatomy of the heart. The pumping action of the heart maintains a continuous flow of blood throughout the pulmonary and systemic circuits. The right side of the heart, part of the pulmonary circuit, consists of the right atrium and the right ventricle. Oxygen-poor blood returns from the body and flows into the right heart, where it is pumped to the lungs. The left side of the heart, which is part of the systemic circuit, consists of the left atrium and left ventricle. Oxygenated blood flows from the lungs into the left heart, where it is pumped to the rest of the body. The term cardiac cycle refers to the contraction and relaxation phases of the heart muscle, or myocardium. One contraction, followed by relaxation, is one heartbeat. Two types of myocardial cells work together to produce contraction and relaxation. They are the myocardial contractile cells and the myocardial pacemaker cells.
The contractile cells cause the myocardium to contract and relax. This rhythmic sequence of contraction and relaxation maintains blood flow. The myocardial contractile cells must be electrically stimulated before they can contract. Pacemaker cells initiate electrical impulses, a characteristic referred to as automaticity. These cells are located in the SA node, the atrial conduction pathways, the AV junction, including the AV node, the bundles of His, and the Purkinje fibers. Initially, the contractile cell is polarized, or in a resting state. Depolarization begins when the cell membrane becomes permeable to the flow of ions. Potassium is the major intracellular ion, and sodium and calcium are the major extracellular ions. First, the sodium ions flow into the cell, then the calcium ions. Potassium ions begin to move out of the cell. When this exchange of ions is completed, the cell is depolarized and contraction occurs. Repolarization begins as potassium ions flow back into the cell and sodium and calcium ions flow out. At this point, the myocardium relaxes. This depolarization and repolarization is referred to as the heart's electrical activity.
What we've just examined is what happens with individual cells. For the heart to pump effectively, this electrical and mechanical response must work together in a well-coordinated manner. Now we can look at conduction of the electrical impulses through the heart and how they control the cardiac cycle.
The sinoatrial or SA node is the pacemaker in the normally functioning heart. It initiates an electrical impulse from its location in the right atrium near the entrance of the superior vena cava. Conduction of the impulse to both atria occurs over internodal pathways and results in atrial contraction. Atrial contraction pushes blood into the relaxed ventricles, filling them completely. The impulse reaches the atrioventricular or AV node, located at the junction of the atria and ventricles. The AV node slowly conducts the impulses flowing through the atria to the ventricles, allowing time for the atria to contract completely and fill the ventricles with blood. From the AV node, the impulse is rapidly conducted through the common atrioventricular bundle, the bundle of His, which further divides into right and left bundle branches. The left bundle divides into anterior and posterior fascicles. The microscopic Purkinje fibers receive the impulse from the bundle branch fibers and directly stimulate the cells of the ventricular myocardium. The result is a forceful, coordinated contraction of both ventricles and ejection of blood into the pulmonary artery and aorta.
The electrocardiogram, or EKG, reflects the timing and amplitude of the heart's electrical activity. Remember, the EKG reflects only electrical activity, not mechanical activity. It can also provide indirect information about blood flow in the coronary arteries. Basically, the electrocardiogram is a recording of the electrical forces produced by the heart. Each part of the waveform has significance. The P wave represents atrial depolarization. The QRS complex represents electrical depolarization of the ventricles. Atrial repolarization is not seen on the EKG because it is hidden by the QRS complex. The T wave indicates repolarization of the ventricles. A U wave is also sometimes seen. Authorities aren't sure what the U wave represents, but it may indicate repolarization of the Purkinje fibers. You may see this in a patient with hypokalemia. Other parts of the waveform are also important. The PR interval begins at the onset of the P wave and lasts until the onset of the QRS complex. It represents the amount of time it takes for the atrial impulse to reach the ventricles. The duration of the QRS complex represents the amount of time for ventricular depolarization. The QT interval is an important measure of ventricular activity because it may be affected by certain types of medications, and when prolonged, may indicate a predisposition to significant heart rhythm disturbances. It starts with the Q wave and ends at the end of the T wave. Let's take a look at the correlation between the waveform and the cardiac cycle.
The SA node fires, and the impulse is conducted through the internodal pathways, resulting in atrial depolarization followed by atrial contraction. This is inscribed as the P wave. As the impulse travels through the AV node, the bundles and Purkinje system, ventricular depolarization occurs, causing the QRS complex to be inscribed. As the ventricular cells return to their resting state by repolarization, the T wave is inscribed.
EKG tracings represent the overall depolarization and repolarization of the atria and ventricles. The standard EKG monitors 12 leads. In general, the EKG complex represents the electrical activity measured between two leads. Although all EKG complexes in a normal cycle have a P wave, a QRS complex, and a T wave, some variation in appearance may occur, depending on the position of the leads monitored. In clinical practice, 4 different leads are typically used for monitoring. 3 of these are the standard limb leads 1, 2, and 3, which are also part of the 12-lead EKG. MCL1, a modification of this.
Esta no va a ser la clásica, porque como han visto, está en una unidad de terapia intensiva, en una unidad coronaria, dice, ¿no ves? Por lo tanto, no lo van a tener crucificado durante, no sé, 3, 4, 5 días que debe estar en la unidad coronaria. Entonces le ponen una unidad telemétrica que manda a una pantalla. Por lo tanto, la persona puede caminar, todo eso, ¿no? Entonces van a ver que es un otro tipo de lugares donde se ponen los electrodos, fundamentalmente en la superficie del tórax, ¿no? Hay uno que es la MSL1 que más o menos emula a la ABR, pero tiene esas características. Van a ver, es negativa como la ADR, o V1 o V2, que tiene esa característica de ser negativa y se ve bastante mejor los voltajes. ¿Lo ven? Pues ya han visto en derivación 1 es más chiquito, en derivación 3 medianito y en derivación 2 es grandecito. Entonces siempre uno debe ir donde se ve mejor, ¿no? Entonces solo esa aclaración hacer, ¿no?
Standard limb leads is also commonly used. 3 electrodes are usually needed. In each, 1 electrode is positive, 1 negative, and 1 is the ground.
La
The
cruz de
ground lead
grado.
can be placed anywhere, but is usually placed just below the right pectoral muscle. In lead 1, the negative electrode is placed in the hollow area just below the right clavicle, and the positive one is in the hollow area below the left clavicle. Typically, the QRS complex is upright in this lead, meaning it has a positive deflection. The height or amplitude of the QRS complex is usually smaller than in leads 2 and 3. The P wave and T wave are also positively deflected. In lead 2, the negative electrode is again just below the right clavicle. The positive electrode is placed below the left pectoral muscle.
Como la dos.
The QRS complex, P wave, and T wave are all positively deflected. In lead 3, the negative electrode is just below the left clavicle, and the positive electrode is just below the left pectoral muscle. As in leads 1 and 2, the P wave, QRS complex, and T wave are positively deflected. However, the P wave amplitude is less, so that recognizing it may prove difficult. In MCL1, the negative electrode remains just below the left clavicle, and the positive electrode is placed over the 4th intercostal space, just to the right of the sternum. In this lead, the P wave is positively deflected and is easily recognized. The QRS complex and the T wave are normally negatively deflected. It really doesn't matter which of these leads is used for monitoring. However, lead 2 and MCL1 are used most frequently. If you change the monitoring lead, be sure to note this information in the patient's chart. And whenever you place a monitor strip in the chart, document the lead that was reported. When you're looking for trends and changes, it's always better to compare monitor strips from the same lead.
Besides correct electrode placement, other factors affect the quality of the information which can be gained from the EKG. The proper technique used to apply the electrodes is one factor. The supplies you will need, besides the electrodes, lead wires, and telemetry unit, are gauze sponges, alcohol preps, a razor if needed, soap, and a washcloth and towel. A disposable floating electrode used in this demonstration is most commonly used for cardiac monitoring. It has a center cushion filled with electrode paste or gel. The outside rim adheres to the patient's skin. Normally, this type of electrode can be left on the skin for 3 to 5 days. Begin by identifying the sites you'll use. This, of course, depends on the lead used for monitoring. In selecting the electrode sites, be careful to avoid bony areas, such as joints, skin folds, old or new scar tissue, breast tissue, and areas of significant muscle mass. In most cases, do not place electrodes over the heart apex, so that in an emergency, they won't be in the way if defibrillator paddles are used. Use soap and water to wash each site. You may need to clip excess chest hair or shave a 10-centimeter circle to improve electrode adherence. Try to avoid shaving if possible, however. Use a towel to dry the skin thoroughly. Then remove excess skin oils with an alcohol prep. Use a brisk rubbing action to create friction. Omit this step for an elderly person or a patient with fragile skin. After the alcohol has evaporated, use dry gauze to slightly roughen the skin. Some disposable electrodes have a spot on the cover that can be used to roughen the skin. Next, connect each of the lead wires to an electrode pad. This avoids applying pressure on the patient's chest after you have placed the electrodes. Remove the cover from one of the electrodes and check the center of the pad. It should appear moist. If it is dry, don't use it. Apply the correct electrode to the correct site. Avoid applying too much pressure, which could force the conductive pad away from the center of the electrode. Work toward the edges of the adhesive disc. If a wrinkle develops, start over with a new electrode. Follow the same technique for each of the other two electrodes. When all the electrodes have been applied, check the lead wires from the telemetry unit. Be certain that the right arm lead wire is connected to the negative electrode, and that the positive or left arm lead wire and grounding lead wire are also properly connected. If the lead wires are long and are likely to become tangled when the patient moves, use non-allergenic tape to secure a stress loop to the patient's chest. Place the telemetry unit in the pouch and secure the pouch. Check the quality of the waveform on the monitor. Look for a prominent P wave. Check the amplitude of the QRS complex. It should be high enough to trigger the rate meter. Also look for any artifact in the waveform. You'll see a straight line if the electrode has come loose, a bizarre wavy line if the patient moves, and very fine wavy lines if there is 60-cycle or electrical interference. Make any necessary adjustments before running the baseline tracing of the waveform.
One more piece of information is necessary before you can interpret the monitor strip. Increments of the standard EKG reporting paper allow you to assess timing and amplitude. The horizontal axis of the graph represents time, with each small square equal to 0.04 seconds. 5 consecutive squares, usually marked by a bolder line, equal 0.2 seconds. And 5 consecutive groupings equal 1 second. The vertical axis represents the amplitude of electrical changes. Each small square represents 0.1 millivolt. A bolder line appears every 5 squares on the vertical axis, with the intervals representing 0.5 millivolt. 2 large squares on the vertical axis, therefore, equal 1 millivolt. 15 large squares equal 3 seconds. Some paper is marked along the top at 3-second intervals. Interpreting your patient's EKG can be difficult at first, but with practice it will become easier. Practice using the 8-step method can help you become more confident and skilled. Step 1, evaluate P wave. Step 2, evaluate atrial rhythm. Step 3, evaluate atrial rate. Step 4, calculate duration of PR interval. Step 5, evaluate ventricular rhythm. Step 6, evaluate ventricular rate. Step 7, calculate duration of QRS complex. Step 8, calculate duration of QT interval. Now let's look at some clinical examples.
To begin evaluating the waveform, look for the P wave, which usually indicates sinus rhythm. Observe its size and shape and where it appears in the waveform. If the P wave is consistently...
¿Qué significa evaluar la onda P? Evaluar es como hace un momento he hecho un repaso para evaluar sus conocimientos, ¿verdad? Lo mismo, evaluar la onda P es si se está comportando como debe comportarse. La onda P debe tener la misma polaridad que el complejo QRS, debe tener también la misma polaridad que la onda T en la mayor parte de las derivaciones, ¿no ves? Porque puede variar en algunas, pero en la mayor parte. Esta onda P siempre debe estar seguida de un complejo QRS, ¿no ves? Porque nace del nodo sinoauricular, viaja vías interneurales, nódulo auriculoventricular, sistema de Purkinje y se produce el QRS, ¿no ve? Siempre debe estar seguido, ¿no? Eso es lo que debemos ver en evaluar la onda P, ¿no ve? Que siempre es bueno, que tenga la misma frecuencia y que sea rítmica, ¿no? El ritmo, se agarra un compás y se mide de aquí, 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 ¿no ve? Quiere decir que se está presentando de manera rítmica, no está antes o después, ¿no? Se va a sacar la frecuencia de la contracción auricular y tiene que ser la misma que de la contracción ventricular, ¿no ve? Algo lógico también, no es muy descabellado.
Followed by a QRS complex. The cardiac cycle is being initiated in the SA node, as it should be, and is being transmitted to the ventricles. Next, look at the atrial rhythm. The P waves should occur with a regular frequency, with only small variations associated with respiration. The interval between P waves, the PP interval, is most easily measured by using calipers. Compare the PP intervals in several cycles. Be certain the calipers are set at the same point, at the beginning of the wave or on its peak. Instead of lifting the calipers, rotate the leg to the next P wave to be certain your measurements are accurate.
The intervals seem to be the same. Does that mean that the atrial rhythm is regular?
Yes, it does.
In step 3 of the assessment, you determine atrial rate. A rapid way of determining the rate is to count the number of P waves in 2 3-second segments and to multiply this number by 10.
I count 7 P waves, so the atrial rate is 70, within the normal range of 60 to 100 contractions per minute, right?
Right.
Step 4 is calculating the duration of the PR interval. Count the number of small squares between the beginning of the P wave and the beginning of the QRS complex. Multiply the number of squares by 0.04 second. The normal interval is between 0.12 and 0.20 second, or between 3 and 5 small squares wide. If it is longer, there is a delay in conduction of the impulse to the ventricles.
I come up with an interval of 0.16.
16016.
Step 5 is to evaluate ventricular rhythm using calipers to measure the RR intervals. Remember to place the calipers on the same point of the QRS complex. If the RR intervals are consistently the same, the ventricular rhythm is regular. Step 6 is to determine ventricular rate, which normally is the same as the atrial rate. Use the same method described to calculate atrial rate. Also check the appearance of the QRS complex and decide if it looks as it should for the lead you are monitoring. Step 7 is to calculate the duration of the QRS complex. Count the number of squares between the beginning of the Q wave and the end of the S wave and multiply by 0.04 second. A normal QRS complex duration is less than 0.12 second, or less than 3 small squares.
On this strip, the duration of the QRS complex is 0.08.
Correct.
0.08, no?
Step 8 is to calculate the QT interval. Count the number of squares from the beginning of the Q wave to the end of the T wave. Then multiply this number by 0.04 second. The normal range is 0.36 to 0.44 second, or 9 and 11 small squares wide.
The QT interval is 0.36. All of the findings are within normal limits, so the patient has a normal sinus rhythm.
Carefully record your findings and compare them to earlier monitor strips. Remember that any monitor strip is only a momentary glimpse into the ongoing activity of the heart, and several readings over a period of time may reveal more comprehensive information than will a single strip. Regularly evaluate the EKG strips of every patient being monitored. Do this at least once every 4 to 8 hours, or whenever a problem is suspected. This patient is a female, age 73. She was admitted 36 hours ago with congestive heart failure and has been receiving Digitalis 0.25 milligram daily and Lasix 40 milligrams twice a day since she was admitted. Her condition has been improving. She's breathing better and her lungs are less congested. Part of your assessment is to evaluate her EKG.
No entienden español, ¿qué hace en inglés?
It appears to be of normal amplitude, and it looks the same each time. Now evaluate atrial rhythm. It appears to be regular.
¿Alguien sabe inglés?
Now count atrial rate.
¿Sabes inglés? ¿En qué hecho puedes traducir?
PR interval duration is the next step. In this example, it's slightly more than 4 small squares multiplied by 0.04 seconds. This yields a duration of 0.18 seconds within normal limits. In some patients, you may see a lengthened PR interval after digitalis is started.
¿Cuál va a ser nuestro objetivo? ¿Cuál va a ser de cada uno de esto otro, de esto otro?
Which is within normal
Hay que
limits.
hacer esos 8 pasos. Ahí está mencionando 9, 6,
The calculation of the QRS complex
medirlo con
is
el
the next
límite.
step. In this example, it is slightly more than 1 small square multiplied by 0.04. This yields a duration of 0.06 seconds within normal limits. Calculation of the QT interval duration is the next step. 11 small squares multiplied by 0.04 gives an interval of 0.44 seconds, just within the range of normal. The next patient was just admitted to the CCU. He is male, age 49, and came to the emergency department complaining of substernal chest pain. In the CCU, a baseline EKG is being reported. The P wave is present. The amplitude is variable. The atrial rhythm is regular. The atrial rate is 90. The PR interval is 0.12. The ventricular rhythm is regular. The ventricular rate is 90. The QRS duration is 0.08. And the QT interval is 0.36. Although all these findings are within normal limits, there is one abnormality we have not yet discussed. The ST segment, the area of the waveform between the QRS complex and the T wave, is usually at the same level as the PR interval. In this patient, the ST segment in lead 3 is significantly elevated. ST elevation indicates reduced blood flow to the heart muscle in the area which the lead is evaluating. In this case, ST elevation indicates acute injury to the heart muscle. The next patient is a 32-year-old man who is having a routine physical examination complete with a 12-lead EKG. The nurse has noted in his history that he jogs 6 to 10 miles daily. Such information is important to consider when evaluating an EKG. The P wave is present, it appears normal, and has a low amplitude. The atrial rhythm is regular. The atrial rate is 50. The PR interval is 0.12. The ventricular rhythm is regular. The ventricular rate is 50. The QRS duration is 0.08, and the QT interval is 0.48. In this patient, the atrial and ventricular rate of 50 is lower than the normal limit of 60. This is known as sinus bradycardia. Brady means slow. Although slow heart rates may be abnormal, in well-conditioned patients such as this one, sinus bradycardia is normal. The last patient is a female, age 28, who came to the ED complaining of heart palpitations and dizziness. During the assessment interview, the nurse learned that she has recently changed jobs and that her new job responsibilities are causing a great deal of anxiety and other stress symptoms. An EKG monitor strip is recorded using lead 2. The P wave is present. The atrial rhythm is regular. The atrial rate is 120. The PR interval is 0.14. The ventricular rhythm is regular. The ventricular rate is 120. The QRS duration is 0.10. And the QT interval is 0.32. The atrial and ventricular rates are 120. Because this heart rate is above the normal limit of 100, it is called sinus tachycardia. The prefix tachy means fast. Sinus tachycardia may be a response to many factors: anxiety, pain, dehydration, fever, blood loss, and others. In this patient, anxiety appears to be the cause for sinus tachycardia. Whenever a sinus tachycardia is seen, an underlying cause should be sought. In review, the 8-step method for interpreting EKGs includes the following steps. Evaluate the P wave. Look at its size, shape, and where it appears.